So let's talk about arterial blood gases and kind of the quick and easy, down and dirty approach to NCLEX ABG questions. One of the things that is going to be very nice about the new next-gen NCLEX that you folks will be taking is that they are going to give you all of your lab values, including the normal values for ABGs. So it's not going to be as important to memorize the normal ABG values, but it's a good thing to have those under your belt. The best way to look at ABGs is to remember one thing: CO2 dissolved in water equals acid. So if you have a person who is retaining CO2, such as a person with respiratory problems, then they're going to be in acidosis because of all the CO2 that is in their blood. So respiratory acidosis, retaining too much CO2. Respiratory alkalosis, blowing off too much CO2, like a person having a panic attack and hyperventilating. Metabolic acidosis, remember the 3 Ds: diabetes, diarrhea, dialysis. Those are 3 conditions that highly predispose our patients to going into metabolic acidosis. Think of diabetic ketoacidosis. Think of patients in renal failure, patients with a lot of diarrhea. They are losing base through their GI tract, their lower GI tract, so they are going into acidosis. For metabolic alkalosis, copious vomiting, NG tube drainage. If you've got stomach acid and all that is coming out along with the food or the NG tube drainage post-op, you are going to be at risk for having low acid or metabolic alkalosis. So use these kind of memory aids as you're looking at scenarios, looking at your patients when you come out of report and say, who's at risk for going into an acid-base imbalance, and what type of acid-base imbalance are they going to be suffering from? Now, your normal values that I use are the pH 7.35 to 7.45, partial pressure of CO2s 35 to 45. Those are the 2 key values that you want to look at first. You want to look at the pH, and the pH is going to tell you if it's normal or compensated, or if they are too low, below 7.35, which means they are in acidosis, or they're above 7.45, and that means they're in alkalosis. So that helps you kind of use the process of elimination when you're looking at what might be going on with that patient. The next important thing to look at is the partial pressure of CO2. Normal range is 35 to 45, and if you look at the last 2 digits of your pH range, 7.35, 7.45, those kind of help you remember because they're the same digits. So if you have a normal partial pressure of CO2, then probably they don't have a respiratory problem. If it's above 45, they're retaining CO2, then there's a very good chance that they are going to be in respiratory acidosis. If it's below 35, it means they're blowing off CO2, and they're going to be in alkalosis. The bicarb can tell you a little bit. Sometimes it can tell you how well or how poorly the patient is compensating. And I use the 22 to 26 for the bicarb, but you may see digits slightly different when you look at reference ranges based on the facility that you're working at. A nice to know, but not really a need to know, is your partial pressure of oxygen, because that will help to confirm whether or not you have a respiratory condition, respiratory problem or complication, because obviously if it's below 80, you're going to be worried. But if it's within that range, 80 to 100, you're doing pretty good. Do not confuse the partial pressure of oxygen with your oxygen saturation, which is expressed as a percentage. And a good oxygen saturation, an O2 sat, it should be 95 to 100. So don't get those confused, because you know those sick, twisted people that write the NCLEX, they could throw those things in there and get you confused as to whether or not you're looking at a partial pressure of oxygen or you're looking at an oxygen saturation percentage. So let's look at some ABG practice examples and see if we can look at the set of ABGs and try to determine an idea, get an idea of what type of acid-base imbalance the patient might be in, just looking at the numbers, and then talk about what is actually happening with this patient and what we're going to do about it. So we have a pH of 7.28 and a CO2 of 56. 7.28 less than 7.35, so we are going to be in acidosis. Now, what type of acidosis, you would ask? Well, we have a partial pressure of CO2, 56. That's high. So chances are this person is in respiratory acidosis. The partial pressure of oxygen confirms that. The bicarb is normal. The O2 sat is a little low. So we are in respiratory acidosis, and it's a 60-year-old male with pneumonia, dyspnea, fever, and chills. So while you're preparing for class, think of what some appropriate interventions might be for that person. What kind of orders are you going to see? What kind of assessments are you going to be focusing on? Okay, how about a pH of 7.28 and a CO2 of 43? pH is low, acidosis, but the CO2 is within that normal range of 35 to 45. So we're guessing, an educated guess, that we have a situation of metabolic acidosis because we are in acidosis, but the gases look good. The partial pressure of oxygen confirms that we don't have a respiratory problem because it's within that 80 to 100 range. The bicarb is a little low. It's trying to buffer, but it's not successfully buffering. And our O2 sat is 96%, which again helps us confirm that we don't really have a respiratory problem. So we have metabolic acidosis, and we have a 24-year-old female with Crohn's disease, a 4-day history of bloody, watery diarrhea. So that's one of the 3 Ds, the metabolic acidosis, 3 Ds. So while you're reviewing this, think about what would be some appropriate interventions, what orders would you anticipate for this patient. Okay, a pH of 7.02, whoa, very, very low, and a partial pressure of CO2 of 55, very high. That's confirmed that we have a respiratory component here, a partial pressure of oxygen of 77, so that's low, but we also have an extremely low bicarb of 14. So that would lead me to believe that we've probably got a metabolic as well as respiratory component, making that patient be acidotic. And in fact, this is an 80-year-old male with urosepsis, confusion, and shortness of breath. So the urosepsis is causing metabolic acidosis. The shortness of breath, where he's retaining CO2, is causing a respiratory component. So we do have metabolic and respiratory acidosis. This would probably not be on an NCLEX question as you having to identify what acid-base problem we have, because we have a combination of 2. But this is how these things can happen with patients with multiple issues with a significantly low pH of 7.02. That would indicate mechanical ventilation. This patient meets the criteria for mechanical ventilation. We need to get his oxygen level up, and we need to drive down that CO2 level and get him into a little bit more of a homeostasis. And also think about what some other appropriate interventions might be for this patient, given the urosepsis and the shortness of breath. What kinds of orders would you anticipate? Okay, we have a 7.37, a partial pressure of CO2 of 63, which is very high, a partial pressure of oxygen, which is 58, which is very low, a bicarb of 35, which is quite high, and an O2 sat of 89%, which is lower than what we would want. But we have a normal pH. So what is your interpretation of this? Compensated respiratory acidosis. Because you're looking at the partial pressure of CO2 and it's telling you we have a potential for respiratory acidosis because of that CO2 dissolved in water equals acid. But the bicarb is high enough to buffer that acid and normalize that pH. So that's why we have compensated respiratory acidosis. It's a 61-year-old female with COPD. What are the appropriate interventions? Now, when I would lecture this in class, a lot of people would say, we got to give her some oxygen. No, no, no. This is her baseline. If you have a patient admitted with chronic obstructive pulmonary disease and they run some ABGs on that patient, you should be very curious about what that's going to show, because many of your patients with COPD are going to present with these types of ABGs. Terrible gases, but a normal pH. So they are compensated. If you give her oxygen, remember it's her hypoxia that drives her respirations. Increased oxygen is going to suppress her respirations, stop her from breathing. So we're just going to keep an eye on her. We're going to monitor her. We will give her whatever oxygen supplementation she's used to getting. Oftentimes they're on 2 liters of nasal cannula, and maybe they're not on any. But watch her for any signs of decompensation, because these are patients who can tip out of compensation very, very easily. But right now, it's her baseline. We're not going to do anything. Okay, a pH of 7.5 with a partial pressure of CO2 of 36. What do we have here? We have a normal CO2, but a high pH. That means they're in alkalosis, not in respiratory alkalosis, because if we were, the CO2 would be low. Oxygen is normal. Bicarb is high. O2 sat is very good, so we don't have a respiratory component. So we're looking at metabolic alkalosis, and it is a 17-year-old female with intractable vomiting. Remember, you've got gastric acid that's coming out, making her alkalotic. So think, as you're preparing for class, what are some of the appropriate interventions? What types of orders do you think you would see with this patient with intractable vomiting? Okay, we have a pH of 7.46, a partial pressure of CO2 of 42, partial pressure of oxygen of 86, bicarb 29, and our O2 sat is 97%. So we have a slightly elevated pH, so there is alkalosis. Partial pressure of CO2 is normal. Partial pressure of oxygen is normal. Bicarb is high if you're looking at the 22 to 26 normal range. O2 sat is good, so we don't have a respiratory component. We have metabolic alkalosis, and it is a 55-year-old male with GERD who takes 15 Tums per day. So think about what some of those appropriate interventions are going to be for this patient. We need to determine why he has this GERD, maybe do an H. pylori test. If that's negative, then that person probably needs to get off the Tums and get into a proton pump inhibitor, a PPI, or a histamine blocker to help with their GERD. And finally, we have a pH of 7, very, very low, very acidotic, partial pressure of CO2 59, elevated CO2, partial pressure of oxygen 86. So the respirations are, the CO2 is a little elevated, but the O2 is okay. The SaO2, the O2 sat is not too bad, but the bicarb is very, very low. So we have another situation. We have a combo problem, metabolic and respiratory acidosis. And what it is a male with type 1 diabetes. So we have one of our 3 Ds for metabolic acidosis, our diabetic ketoacidosis, potentially. And we have pneumonia, which can cause an elevated CO2 and respiratory acidosis. So we have a very, very low pH, and this patient is in metabolic and respiratory acidosis. So think about your appropriate interventions. The very low pH is going to necessitate mechanical ventilation, but think about what are some of the other orders you anticipate with this type of problem. So that concludes some practice ABG examples on how you can kind of look at an NCLEX ABG question and figure it all out based on just the pH and the partial pressure of CO2.